This subcommittee will come to order. Just a word about this morning's proceedings. Because we have a joint session of Congress today at 11 o'clock, we will begin our hearing at 10:30 with members' opening statements and then recess shortly before 11 for members to move to the Capitol for the session at 11. We will reconvene our hearing immediately following the joint session at 12:15 and start with our introductions of witnesses, their 5-minute statements, followed by the members' questions under the 5-minute rule. Chair will recognize himself for an opening statement for 5 minutes. The title of this hearing is Setting Fiscal Priorities in Health Care Funding. And that is exactly what we must do, assess and prioritize all of the things that we need to do and would like to do, and then make difficult funding decisions with limited amounts of money. Today we will address 5 areas of the health reform law and determine if these funding streams are needed, if these programs are funded at the most responsible levels, and if they should be mandatory or discretionary. Section 4002 of PPACA establishes a Prevention and Public Health Fund, quote, to provide for expanded and sustained national investment in prevention and public health programs to improve health and help restrain the rate of growth in private and public sector health care costs, end quote. The section authorizes the appropriations of and appropriates to the fund from the Treasury the following amounts: $500 million for FY 2010, $750 million for 2011, $1 billion for 2012, $1.25 billion for fiscal year 2013, and $1.5 billion for 2014, and for fiscal year 2015 and every fiscal year thereafter, $2 billion. The Secretary has full authority to use this account to fund any programs or activities under the Public Health Service Act that she chooses without congressional oversight. On June 18, 2010, HHS announced $250 million in prevention and public health fund dollars would go, quote, to support prevention activities and develop the nation's public health infrastructure, end quote. On September 27, 2010, HHS announced another $320 million in grants from the fund to expand the primary care workforce. And on February 9, 2011, HHS announced an additional $750 million from the fund for various prevention activities, including preventing tobacco use, obesity, heart disease, stroke, and other diseases, and increasing immunizations. The goals of these 3 disbursements from the fund are laudable, and there's no doubt that we must focus on preventing disease. But we must remember that this funding is over and above the amount that Congress has decided should go to these activities and the amount that Congress has already appropriated for these activities. It is also dispersed at the sole discretion of the Secretary. Last Thursday, I asked Secretary Sebelius whether she needed further congressional approval to spend the money from the 4002 fund, and she answered no. I then asked her if she could fund activities above and beyond the level Congress appropriated, and she stated yes. This should concern every member that we have created a slush fund that the Secretary can spend from without any congressional oversight or approval. By eliminating this fund, we are not cutting any specific program or activity. We are reclaiming our oversight role of how federal tax dollars should be used. This time I'll yield 1 minute from the gentleman from Texas, Mr. Barton.
Thank you, Mr. Chairman. I want to welcome especially Mr. Ishtook and Dr. Goodman. They're both personal friends of mine, and Mr. Ishtook's a former congressman. This is a very important hearing, Mr. Chairman, because we're coming to find out every day more and more things about the health care law that should be of concern to every American citizen. The ability of the Secretary of HHS, without any oversight or any authorization of the Congress to spend such sums as necessary, which could total into the billions of dollars, is something that should concern everybody in this room. And this hearing, to look into that part of the law and then look at some of the other specific sums that are authorized, if we're really going to get spending under control, this is ground zero for starting it. So I appreciate you holding the hearing. I appreciate all 3 witnesses for being here. And again, to Dr. Goodman and to Mr. Ishtook personally, welcome to the committee. Thank you, Mr. Chairman.
Chair thanks gentlemen. Yields remaining time to Mr. Latta from Ohio.
Well, thank you, Mr. Chairman, for holding this hearing today on fiscal priorities for health care spending. As we continue to discover more and more details of the ramification of Obamacare, I am extremely troubled by the fact that this bill put in place programs and spending that bypass Congress and gives full control to the administration. There are several programs that have been identified in Obamacare that are duplicative government programs as well as mandatory spending programs. I have grave concerns about these duplications and the fact that the programs contained in Section 2953 are of this nature. I'm very supportive of the discussion draft before us that will convert the appropriation contained in this section of $75 million for each of the fiscal years 2010 through 2014 into an authorization. Congress needs to be the one that determines funding through these programs and determines if, in fact, they are duplicative and determine this through the normal appropriation process. Making this change could potentially save $375 million over 5 years. This is a huge savings at a time when we must get our fiscal house in order, and there are many more savings by fully repealing Obamacare. This past month, the Congressional Research Service updated an October 2010 report that appropriations and fund transfers in the Patient Protection and Affordable Care Act. The new report found that, unbeknownst to almost every member of Congress, that Obamacare contains $105 billion in direct implementation spending that bypasses Congress's normal appropriation process. Thank you, Mr. Chairman, and I yield back.
Gentleman's time has expired, and Chair yields for 5 minutes for opening statement. The ranking member, Mr. Plum.
Thank you, Mr. Chairman. Here we go again, same song, different verse, another hearing that continues the Republican hollow agenda of round-the-clock complaints of Democratic legislation without a glimmer of their own innovation or substance. The American people can do the math. 10 weeks, 0 jobs bills from the GOP. Months after the election, Republicans continue to put partisan politics ahead of Americans' top priority, which is jobs. But I should say I welcome the opportunity to talk about health care reform and health security. I'm very proud of the benefits it will bring to millions of hardworking Americans nationwide and for the families that live in every single congressional district of the members of this committee. But while I welcome an honest discussion about reform, the issues raised today border on the absurd in my opinion. The Republicans couldn't be more hypocritical with their seeming concern about the use of mandatory funding for some of the programs in health care reform. This hearing isn't about funding streams. It's simply an effort to dismantle the health care reform law block by cherry-picking policies they don't care for without offering any solutions in return. The truth of the matter is that the last time Republicans were in charge, they embraced mandatory health care funding, and they used it regularly in bills that passed through the Energy and Commerce Committee. The Medicare Modernization Act of 2003, I'm sure we all remember that bill. It passed in the middle of the night after a 3-hour vote was held open on the floor, and that bill was chock full of mandatory goodies. There was the $1.5 billion to fund startup administrative costs for implementation of MMA, and there was an unlimited appropriation to fund the Transitional Drug Assistance Program, and there were a few $100 million in change for a health infrastructure program and another $1 billion for emergency health services, all mandatory funding. And then you can fast forward a couple years, and the committee once again decided to use mandatory funding for billions of dollars worth of programs throughout the so-called Deficit Reduction Act of 2005. And I could spend my whole 5 minutes on that, but I'm going to spare you that one. The fact is that key programs under the jurisdiction of the Energy and Commerce Committee are and continue to be funded through mandatory spending authority. It's a way to ensure an adequate and sustained funding stream to ensure the success of important programs. And for the Republicans to cry foul because we happen to utilize this tool in the Affordable Care Act is simply not credible. And it continues to amaze me how the Republicans cry states' rights at every turn, and then undermine that same principle with gusto. They want to eliminate all the funding for state health exchange grants. You tie the states' hands, and you're not only going to throw an unfunded mandate on them, but in effect you're ceding states' powers to the federal government and telling HHS to step in and tell states what insurance exchange model will work best for them. That wasn't our policy. We wanted state innovation in the health care reform bill, and we urge our Republican colleagues to rethink their misguided proposal. As much as I disagree with the basis for this hearing, I'm pleased to welcome my good friend, State Senator Joe Vitale, who's from New Jersey. He's testified before us several times on health care reform, and He'll talk about how health care reform will help millions of New Jersey families and how New Jersey already benefited from more than $3 million in critical funding from the Prevention and Public Health Fund. So at this time, I'd like to yield 1 minute to the gentleman from New York, Mr. Engel.
Thank my friend for yielding, and I agree with your sentiments. Mr. Chairman, this hearing calls to mind the classic line from Yogi Berra, it's deja vu all over again. This hearing really isn't about the difference between mandatory and discretionary funding. This hearing is really another veiled attempt to undermine the Affordable Care Act and prevent 30 million Americans from accessing affordable health coverage. According to the majority, the Affordable Care Act was, quote, unusual in that it created mandatory spending on programs that would otherwise be considered discretionary, unquote. It seems my friends on the other side of the aisle have a short memory. The Republican majority mandated open-ending spending on new programs in the Medicare Prescription Drug Improvement and Modernization Act and the Deficit Reduction Act, both of which have resulted in billions of dollars spent outside of the appropriations process, and worst of all, were unpaid for federal mandates. No jobs created by the majority, just tax breaks for the rich and big corporations, blowing a hole in the deficit, and again and again and again, day in and day out, attempts to repeal the health care law, which is already helping millions and millions of Americans. I yield back.
Whatever time I have left, I yield to Ms. Schakowsky.
Let's take a look at factcheck.org. This ridiculous idea that somehow there's a dirty little secret, as our former colleague Mr. Istuk said in the bill. What it's really about is what he said, pulling out Obamacare weed by weed. This is another attempt to repeal the legislation that will help 30 million Americans. I look forward to having this conversation with Mr. Istuk.
The Chair, the gentleman's time has expired. The Chair recognizes the Vice Chair of the committee, Dr. Burgess, for 3 minutes.
I thank the Chair for the recognition. So here we are, just 2 weeks shy of the anniversary date of that big signing ceremony down at the East Room of the White House. We all remember how the Vice President characterized that morning. So, but this bill does represent, this law now represents a fundamental change of the relationship of the government with the people. We've gone from government with the consent of the governed to now the government telling the governed what they shall get and when they should get it. Remember President Obama, when he was running in 2008, he made two promises. One was, if you like what you have, you can keep it. And the other was, we have to control costs, that way more people can buy insurance. Actually not bad ideas. What happened to, if you like what you have, you can keep it? Well, apparently that's gone by the wayside. And what the American people told us in the difficult summer of 2009 was, we're scared to death you're going to screw up what we have. Please don't do that. And the other part of that equation was, could you do something to help us with costs? Because we are dreadfully concerned about the cost of health care. Turns out, with the signing of this law, we screwed up what was working and we exploded the costs. Now, I do understand the difference between an authorizer and an appropriator. I've been an authorizer during my short congressional tenure. Mr. Istuk, when he was here, was an appropriator. My first field trip out to the NIH, I was taken to all of these big, beautiful buildings, all named after appropriators. I said, where's the building named after the authorizer? There aren't any. But I do understand the very fundamental nature of what we do as an authorizing committee. It is our heritage. And our strength comes from carefully investigating and carefully vetting those expenditures that we then pass off to the appropriators to eventually write the check. And the oversight function that occurs at the authorization level is something which cannot be minimized. We've gone through almost a year of this. In fact, we went through the first 10 months before we had a single oversight hearing from any of the relevant federal agencies over what just was going on with the implementation of this. Now, look, we are all hearing today about the problems with the federal budget. February, $223 billion overdraft. February, I might remind people, is the shortest month of the year. That means that's as good as it's going to get this year, $223 billion overdraft. And what do we get for it? Do you see new clinics? Do you see new schools? No, what you see is an overdraft. And it gets worse because as this thing is implemented, we go on to subsidies to middle-class families in the exchange to help them buy health insurance. And the answer there is a tap with a high-pressure line into the federal treasury. That $223 billion deficit is something for which we will all wax nostalgic after that kicks in this bill. The mandatory spending, which we are all talking about, needs to be brought back under the control of this committee and be authorized. You don't have to be against something just because you want to label it mandatory. It simply means you want to have the correct amount of congressional oversight. Let me yield at this point to the gentleman from Kentucky.
Thank you, Thank you for yielding. Thank the gentleman for yielding. You know, this is, we are working on jobs. Everywhere you go, you hear people and businesses are sitting on the sidelines not investing because they're not sure how much their employees are going to cost them because of the expense that's coming because of this bill. And also, we need to address spending so American people can and businesses can have money to create jobs. And every day, families across this country are sitting around trying to figure out what to spend their money on. And I believe Congress should follow suit. Unfortunately, during the annual appropriations process, Congress's equivalent of a family budget, a number of federal programs are off limits because they were created as mandatory spending and not discretionary. These programs are not subject to the same scrutiny or evaluated for effectiveness in order to earn their continued funding. The new health care law created an unprecedented number of these mandatory programs. One that we will discuss today is an authorization of a mandatory spending program for graduate medical education. While I support graduate medical education, believe we need more residency positions, particularly primary care, I support shifting this program to an authorization. This program should stand on its own merit and not be protected and prioritized over other similar programs. This change is not only physically responsible, but good policy. Thank you, Mr. Chairman. I yield back the balance of my time.
Chair, thanks, gentlemen, and yields 5 minutes to the ranking member, Mr. Waxman.
Thank you, Mr. Chairman. What the Republicans are conjuring up today is a completely contrived issue about funding for the Affordable Care Act that is entirely false and misleading. Don't fall for it. The Republicans are trying to turn back the clock on the Affordable Care Act, a law that reduces the deficit by over $210 billion in the next decade, expands the health care coverage to 32 million people, closes the Medicare drug donut hole, provides free preventive care under Medicare, and strengthens the Medicare Trust Fund. And it prohibits predatory, abusive behavior by insurance companies. It addresses public health challenges that confront our nation, such as obesity and health disparities, through support of the public health infrastructure. This hearing is about having appropriate resources to fund the Affordable Care Act. The Republicans tried to repeal that law, but they weren't successful. So now they're trying to defund it in another way. Every member of this committee has a history of voting for both mandatory and discretionary spending. In fact, a Republican-led Congress passed legislation that included over $400 billion of mandatory spending that was not paid for in the Medicare drug bill. It's a fundamental part of the responsibility of an authorizing committee like Energy and Commerce that has jurisdiction over programs like Medicare, Medicaid, and CHIP to determine where mandatory funding is needed to ensure a program's sustainability. Similarly, assuring funding to implement and to support the Affordable Care Act is critical to its viability and success. The legislative proposals being discussed today are marked by irony and hypocrisy. For example, one proposal repeals the money for the states to establish their exchanges. Just last week, we had a hearing where Republicans argued the need for state flexibility under health reform and discussed the fiscal constraints that face states today. This proposal would take away money that would allow the states to do the work necessary to design a health insurance exchange that meets the needs of their residents. Our members have been discussing the need for expanded health care workforce, especially primary care physicians to serve the growing demands for service. And according to his testimony, Dr. Goodman agrees. It's ironic that one of the Republican proposals cuts support from our health care workforce. And a third proposal, they claim that education programs aimed at decreasing teen pregnancies should not have a stable funding source. However, Republicans, including Representative Istuk, fully support mandatory funding for abstinence-only programs and have voted numerous times for such programs. Well, I look forward, I suppose, to the hearing from our witnesses and seeing where this bill will go. I want to apologize ahead of time. I'll need to leave this committee to attend another hearing in another subcommittee. I want to yield 1 minute to Ms. Capps, and then take back my time after that to yield further to.
Thank you, Mr. Waxman. I'll add that today's hearing is another effort by this subcommittee to do everything it can to repeal the Affordable Care Act and avoid the issue Americans care most about, which is jobs. But unlike previous efforts that just ignored job creation altogether, today's hearing is on legislation that will flat out hurt our economy and keep people out of the workforce. For example, the school-based health center construction grants will enhance the health of children and their families, but also stimulate the economy of local communities with new construction jobs. Similarly, the Teaching Health Centers program not only expands primary care services to those who need it most, but also trains new providers with the expertise needed to serve these expanding populations. The Republican majority has placed both of these programs on the chopping block. Let's be clear, these proposals take away funding from shovel-ready projects in our communities, and they keep qualified applicants away from the primary care workforce. I know many of our colleagues will say that our budget requires us to make tough calls. It's not being tough to go after kids in the underserved. These aren't tough calls. They're bad calls. I yield back the balance of my time to Mr. Waxman.
Thank you very much. I want to yield 1 minute to the distinguished Chairman Emeritus of our committee, Mr. Dingell.
Thank you very much for that. I appreciate your courtesy. Today's hearing is a wasted opportunity to have a substantive conversation as to how this committee can work together in a bipartisan fashion to further improve our health care system. I understand that the majority has concerns about the reform. So do we. But we've also heard repeatedly about their belief that the health care reform law will destroy state budgets, kill jobs, drive up health care costs, and overwhelm Medicare and Medicaid. But I see nothing that they're putting on the table to address these problems. Yet while my colleagues take great joy in extolling the problems of the health care reform law, they have not brought forward a single substantive suggestion for improvement. We can see clearly from the 5 discussion drafts from us before us today that the majority has no intention of working with the minority to improve the health care reform law. I've long said that no law is perfect. The last perfect law that came in the hands of men came on stone tablets off the top of Mount Sinai in the hands of Moses. And I believe that you're going to find that the draft legislation that you have submitted to us or will be submitting to us is going to be bad legislation. And indeed, you are letting the perfect be the enemy of the good. It's my sincere hope that this committee will work together to improve this bill and not blindly tear it down. Further, I hope that the next hearing before this subcommittee will take some time to deal with the real problems and the substance of health reform and not the politics. Thank you.
Gentleman's time has expired. The opening statements are concluded. We will recess for the joint session at 11. The joint session may end early, so I would urge the members to return 15 minutes after the closing of joint session. So we'll recess until approximately 12 o'clock or before, if we can do that. The committee's in recess. The time of the recess having expired, the subcommittee will come to order. And I'd like to welcome the 3 witnesses at this time. Note that your written testimony will be entered into the record, and we'll ask you to please summarize each of you for 5 minutes in your testimony before the questions. Let me introduce 2 of the witnesses, and then I'll ask the ranking member to introduce third witness. First of all, the Honorable Ernest Istook serves as a distinguished fellow at the Heritage Foundation. Prior to joining Heritage, Mr. Istook served the people of Oklahoma's 5th District for 14 years, and he was a member of the House Appropriations Committee. Secondly, Dr. John Goodman is with us. He is the President and CEO of the National Center for Policy Analysis. Dr. Goodman is an expert on consumer-driven healthcare reform. He received his Ph.D. in economics from Columbia University. Welcome. And I'll turn to the ranking member to introduce his witness.
Thank you, Mr. Chairman. I already mentioned Senator Joe Vitale. He's testified before our subcommittee on at least 2 occasions in the last Congress, I believe. And he was the chairman of the Health Committee in the State Senate. He continues to be a senior member of the Health Committee. And he doesn't actually live in my district, but his majority or a good portion of his state Senate district is in my congressional district. He's a friend, but beyond that, he really is, I would say most people in the state would consider him the #1 expert on health care in New Jersey. So good to see you.
Thank you and welcome. Now, Chair recognizes the gentleman, Mr. Istuk, for 5 minutes for his opening statement.
Thank you, Mr. Chairman. And of course, you have my written testimony. We're here talking, of course, about the authority for funding and the actual appropriations that were made within what's known both as the Patient Protection and Affordable Care Act, or PPACA, and also known as...
Is your mic on?
Let's try it now.
That's better.
Okay, I'll begin again, if I may. Thank you, Mr. Chairman, for having us here. We're here, of course, talking about the funding approaches taken within the health care legislation that was passed last year, formerly known as the Patient Protection and Affordable Care Act, PPACA, also known to many of us as Obamacare because of President Obama's crucial role as the driving force. This legislation was so unwieldy and complicated that even now people are discovering things that they didn't realize about the legislation. And I compare it to the ability to hide a lot of needles inside a haystack that contains 2,700 pages. And people are at different times finding the challenges presented by that. Although original estimates said that the bill created 159 new government agencies, the Congressional Research Service later concluded the actual number of new agencies, boards, and so forth is currently unknowable because so many of those are given the authority to sprout off new entities in return. The new law attempts to bypass the normal appropriations process, which is another feature that makes it more difficult to deal with it. And for we who believe that the bill should be repealed, and if not repealed, then defunded, that presents special challenges because so many advance appropriations were made. Advance appropriations are actual appropriations for future fiscal years. The comparison is to think in terms of writing checks. If you say I'm not going to write any future checks for something, you're trying to defund it. However, if there's already a series of post-dated checks out there, you have not defunded it. And I realize that's the subject of a major political battle that we have in Washington. And of course that violates the typical congressional process of appropriations. I spent 14 years as a member of the House Appropriations Committee, several of those years as a subcommittee chairman. Typically, the normal process is you create enacting legislation, so-called authorization bills that authorize spending, and then the second half of the process is that appropriations are made in the amount that they deem to be proper at the time. Now, I'm not aware personally of any occasions where we've had advance appropriations not just for one fiscal year in the future, not just for 2 fiscal years in the future, but for 3, 4, 5, 6, 7. In fact, the legislation actually contained funding, actual appropriations, spread out over 10 different appropriations and fiscal years. Now, what happens when you do that is, in essence, you make an attempt to handcuff the current elected members of the Congress. You could just as easily decide spending levels for a future fiscal year, say 2079. You could pass a bill now that seeks to control what spending is going to be 5 years, 10 years, 50 years in the future, but it would not be good practice. The people who should make the key funding decisions for the current time are the people who are elected to serve and represent the public at this particular time. So I'm glad that you're looking at legislation to pull back funds previously appropriated to PPACA or Obamacare, which in essence is putting a stop payment order on these post-dated checks. But it's important that this be done both through the authorizing process and through the appropriations process, where there is also authority to repeal these existing appropriations and to pull them back. Defunding is a very routine policy tool for Congress and for the White House. So is funding at levels below what is authorized. As noted by the Congressional Research Service, Congress is not required to provide funds for every agency or purpose authorized by law. One of our founding fathers, James Madison, said it's the power over the purse which is the most complete and effectual weapon with which any constitution can arm the immediate representatives of the people. However, if the decisions were made by the last Congress, by the prior representatives of the people, then you don't have the same power that James Madison said was essential as a safeguard of the public purse. I should mention that the White House also routinely proposes not funding programs which have been authorized or funding them at beneath authorized levels. If we intend for a policy to bind future generations, we should follow the supermajority process that would actually enshrine that in the Constitution. We should not accept that a simple act of Congress today should be elevated to handcuff a future Congress, nor that the last Congress should handcuff the current Congress. Thank you, Mr. Chairman.
Chair thanks the gentleman and recognizes Dr. Goodman for 5 minutes for opening statement.
Thank you, Mr. Chairman, members of the committee. My name is John Goodman. I'm president of the National Center for Policy Analysis. I'd like to begin by saying there are serious structural problems in the Affordable Care Act, and they are so serious that even if the critics weren't around, the Congress is going to have to go in and make major structural changes to this bill. Let me just draw your attention to a few of them. First, people are going to be required to buy an insurance plan whose cost is going to grow at twice the rate of growth of their income. You don't have to be a mathematician or an accountant or an economist to know that if you have to buy something whose cost is growing at twice the rate of growth of your income, eventually it's going to crowd out everything else that you're consuming. That's an impossible path. It wasn't created by President Obama or by Congress, but the bill, the Affordable Care Act, locks us onto that path and takes away a lot of the ability that people need in order to get off of it and move to a lower-cost health care system. Secondly, there are a bizarre system of subsidies in the Act under which people at the same income level get radically different amounts of help from the federal government depending upon whether they are in Medicaid, whether they're in an employer plan, or whether they are in the exchange. For example, a family at an income level of $30,000 a year in the health insurance exchange will get more than $16,000 of help from the federal government. That same family at work gets the current tax break, which is a little over $2,000. I think this huge discrepancy of subsidies is one of the reasons why the job market is not responding better than it is right now. There is enormous uncertainty right now on the employer side. But eventually, this is going to be very, very disruptive, and eventually I think everybody who is average income or below average income is going to lose his employer-provided health insurance. The numbers are just so large, and the incentives are just so great. They will either go into Medicaid or they will go into an exchange, where the subsidized plans, if we follow the Massachusetts example, will pay a little better than Medicaid rates. Essentially, you can think of it as Medicaid plus. Number three, in the exchange itself, we are creating perverse incentives for insurers. They will have to take all comers for the same premium. They will try to attract the healthy and avoid the sick. After people enroll, they will have an incentive to over-provide to the healthy, because those are the ones they want to keep. They want to attract more just like them. They will have an incentive to underprovide to the sick because they didn't want them in the first place. They certainly don't want to attract any more just like them. I think this is one of the worst features of the bill, and it's the one that has been the least talked about in Congress and outside Congress. On the other side of the exchange, from the buyer's point of view, the incentives are also perverse. In Massachusetts, people are going bare while they are healthy. They get sick, they enroll, they pay premiums for a few months, get their health care, get their bills paid, and then they drop coverage again. So far, we're only talking about a few thousand people, although the number is growing every year. In a state like Texas, where we're signing up people for Medicaid in the emergency room, this would be absolutely disastrous. Number 5, we have promises that we can't possibly keep. This bill will ensure between 32, 34 million additional people. If the economic studies are correct, these people will try to consume twice as much health care as they have been consuming. In addition, almost everybody else is going to be pushed into a plan where benefits are more generous than they are now. There's a whole long list of preventive services that have to be made available with no deductible, no copayment. Bottom line, we're going to have a huge increase in the demand for care. The bill has no provision for increasing supply. So we're going to have a huge rationing problem. And that is going to be very, very bad for anyone whose plan pays below market rates. And who are those people? That's everybody in Medicare, everybody in Medicaid, and maybe everybody who's getting subsidized insurance in the health insurance exchange. And finally, we have impossible benefit cuts for seniors. We're paying for more than half the cost of the reform by cutting spending on Medicare. What are we talking about? Well, for someone reaching the age of 65 this year, the reduction in Medicare spending will be about $35,000 in present value terms. That's equal to about 3 years' worth of benefits. For a 55-year-old, the day that the President Obama signed the bill, they lost $60,000 in spending, and for 45-year-olds, it's $100,000 in spending. Where are all these dollars coming from? I heard on TV this morning they were going to come from eliminating waste, fraud, and abuse. Well, that is ridiculous. Where it's going to come from is in reduced payments to doctors and hospitals and other providers. According to the Medicare chief actuary, by the end of this decade, Medicare will be paying doctors and hospitals less than Medicaid. Senior citizens will be behind welfare mothers in terms of their attractiveness to physicians. In just 3 years, most of you will be flooded by phone calls from constituents telling you they can't find a doctor. I think it's a very, very serious problem and one that the Congress has not yet addressed. The appropriations process is not the only way to deal with this, but congressional oversight is certainly a beginning.
Chair, thanks, gentlemen. And recognizes Senator Vitale for 5 minutes for opening statement.
Thank you, Mr. Chairman. Good afternoon, Chairman Pitts and members of the Subcommittee on Health. My name is Joe Vitale. I was elected to the New Jersey State Senate in 1998 and had the distinct pleasure of serving with your colleague, Congressman Leonard Lance. In fact, he is my congressman. Congressman Pitts, Congressman Pallone, Congressman Waxman, thank you for the invitation to testify regarding proposals that would defund critical pieces of the Patient Protection and Affordable Care Act. I want to limit my testimony to how PPACA will benefit New Jersey citizens and how the Act has already begun to do so, and how defunding elements of reform will only serve to undermine access to our state's uninsured citizens. In addition, I will cover some ground on how federal and state health care partnerships have already made a significant difference in the well-being of hundreds of thousands of New Jerseyans. New Jersey was recently awarded a $1 million health exchange planning grant. The State Department of Banking and Insurance awarded nearly $250,000 of that money to the Rutgers University Center for State Health Policy, which is a nonpartisan, evidence-based think tank to hold stakeholder sensing meetings. The center will provide input it gathers through these meetings and to provide to the state and other stakeholders, including legislators. With the remaining funding, the department has planned to hire consultants to inform policymakers of aspects of an exchange, such as design, development, and oversight. In short, an exchange designed specific for New Jersey will contemplate and deliver a well-thought-out mechanism where hundreds of thousands of currently uninsured New Jerseyans will gain access to affordable and sustainable health care coverage. It is my belief that a properly financed and implemented exchange as made available through PPACA is smart, efficient, and a sustainable way to access the appropriate care. The public health initiatives are the single most proven method of controlling health care costs. Vaccinations, workplace safety, infectious disease control, safe food handling, prenatal care, and family planning are just a few examples of how population-based prevention and public health programs are the most effective investment Congress can make to control future health care costs. One example is through PPACA, is where New Jersey received $350,000 for an HIV prevention grant. With these funds, we have tested an alternate means of confirming HIV that replaces a more expensive test at a fraction of the cost. Defunding public health initiatives will have a devastating consequence for all of the people we serve. All the components of PPACA that are to be considered for defunding, rolling back expansion of school-based health centers may be the most short-sighted. 5 years ago, I worked with the Visiting Nurse Association of Central New Jersey to create a non-traditional school-based health services program in the suburban middle-class town in which I live. Children enrolled in the program are able to see a visiting advanced practice nurse within the school nurse's office. APNs are licensed and able to diagnose and recommend treatment. Prescriptions are called into the student's pharmacy so that they are ready for their parents to pick up on the way home. Children are treated faster, return to the classroom sooner, and parents miss less work that many times adds up to less income and employee productivity. At the request of parents, the Visiting Nurse Association now provides annual sports evaluations for their students. School-based health centers require a relatively small investment and provide an enormous return on that investment. Through PPACA, New Jersey has received several grants to address primary care workforce shortages. Defunding programs aimed at addressing these critical shortages, for me, may be the most reckless. The primary care workforce shortages impact every state and will reach critical levels as access to health care coverage is expanded. It takes 10 years to produce a physician and 8 years to produce an advanced practice nurse. In New Jersey, we are already aggressively addressing this issue, though we cannot go it alone, and PPACA will make an enormous difference. A loan redemption program has been created to encourage nurses to pursue nursing faculty careers. PPACA dedicated $800,000 to this program and will help ensure that New Jersey's healthcare system can handle the increased demand. Through PPACA, New Jersey's Department of Labor was awarded $150,000 Workforce Development Primary Care Grant and has received $10,560,000 to increase the number of resident physicians trained in family medicine, general and internal medicine, and pediatrics. Defunding primary care workforce development will cripple healthcare delivery in states that do not already have existing healthcare workforce development programs in place. As one of the original authors and ongoing supporters of New Jersey's S-CHIP program, I can tell you firsthand just how effective federal and state partnerships can be. Currently, New Jersey enrolls over 600,000 children in S-CHIP and in Medicaid. Additional 600,000 parents and adults without children in S-CHIP and in Medicaid as well. Many also contribute to the cost of that insurance. I'll close by saying that most of us elected officials enjoy some of the best health insurance that taxpayer dollars can subsidize. I think it's fair and right that we extend that same generosity to millions of Americans who may never have that same opportunity. Thank you.
Chair, thanks, gentlemen. Thanks all the witnesses for their testimony, and we'll now turn to questioning. The chair recognizes himself for 5 minutes for questioning. Mr. Istuk, regarding state exchange grants, which unlimited mandatory expenditures, the size of the appropriations really at the discretion of the secretary with such sums. In your years as an appropriator and legislator, have you ever seen Congress grant an administration official an unlimited tap into the U.S. Treasury?
No, Mr. Chairman. I can recall no such instance, and furthermore, I think it violates what the Constitution intends when it says no spending shall be made except by appropriations from the Congress, and to leave the amount at the discretion of any public official, whether it be the Secretary of HHS or anyone else, I think is not in keeping with the constitutional intent.
As our national debt currently sits at over $14 trillion, each citizen is individually responsible for roughly $45,000 of debt. We also heard news earlier this week that in February, the shortest month of the year, the federal government ran its single largest monthly deficit in U.S. history, $223 billion. In analyzing this law, we have found 2,000 the Secretary's shell statements. With these facts in mind, do you think it is appropriate to give a single administration official an unlimited tap into the U.S. Treasury?
No, sir. I do not believe that's an appropriate thing to do. Just as it would not be appropriate for you to entrust all of your personal finances and investment to some individual and leave out your own discretion and control over them.
Now, Section 4002 of PIPACA creates a fund to provide funding for programs authorized by the Public Health Service Act for prevention, wellness, and public health activities. From the period fiscal year 12 to fiscal year 21, there will be $17.75 billion deposited in that fund. Who has the authority, Mr. Istook, on how to determine how these funds are spent?
Under the statute, that authority appears to rest solely with the Secretary of Health and Human Services.
And so the Secretary can spend this money without any further congressional action, is that correct?
Yes, because it's already appropriated and the Secretary is given discretion to decide how it's been spent. Then Congress does not need to take further action to authorize the Secretary to do that, but it would need to take further action to stop the Secretary from spending that fund freely as they may see fit.
Does the program's appropriations sunset at any point?
I do not find any sunset in the legislation. If it's there, I'm sure somebody else would point it out to us.
So the HHS Secretary will receive a $2 billion annual appropriation for this program in 2030, in 2040, or in perpetuity, regardless of the effectiveness of the program or the need for these funds?
So long as the Secretary doth live. That appears to be the case.
All right, let's go to Dr. Goodman. As a general proposition, do you believe the massive health care law signed by President Obama responsibly set federal spending priorities in the health care field? And please elaborate.
No, I do not. Just my back of the envelope calculation suggests that for every $2 of spending, only $1 is actually paid for, and if Congress has to restore the spending for seniors, it means only $1 out of every $4 of promises is actually paid for. So there's a commitment here to spend an enormous amount of money, and no idea, and no one can tell me where the money is going to come from.
All right. Senator, in your testimony, you argue that the massive new health care law does not expand government's role in the health care arena. Are you aware that PIPACA adds 20 million Americans into the government-run Medicaid program?
Yes.
Are you aware the health care law creates at least 159 new agencies, boards, and commissions?
I'm not aware of that total number, but I'll take your word for it, Mr. Chairman.
Are you aware that the Secretary of HHS has the power to prevent doctors and hospitals from contracting with insurers if they fail to meet new federal guidelines and standards?
Yes, and I agree with her.
Are you aware that the Secretary of HHS can dictate the benefits, the network adequacy requirements, the medical loss ratios, the actuarial value, and the other terms of every health plan in America, including new requirements on plans that Americans have and like today?
Someone should, and the responsibility rests with her.
Thank you. I'm sorry. I'm out of time and yield 5 minutes to the ranking member, Mr. Sloan, for questioning.
Thank you, Mr. Chairman. I wanted to ask a question of Senator Vitale. 48 states and D.C. received grants for the purpose of planning and establishing an exchange. In addition, 6 early innovator grants were awarded to develop an array of models for exchange information technology systems that can be used by other states. So about $296 million has gone out to states for these grants related to the exchange. Now, the Republicans, criticize again and again that they do not want a federal solution for health reform. But the fact is, if a state does not or is unable to establish a state exchange, the federal government would establish one for them. So these planning and establishment grants provide the necessary support to ensure states are able to work with their stakeholders. If it's an active exchange, it negotiates with insurers to leverage the best quality choices for best prices, or it's an open exchange that invites all insurers to offer products that consumers can be aware of or choose from. These grants basically make all this possible and make for good exchanges. So I wanted to ask you, Senator, if Congress were to repeal this provision providing for grants for the states for exchanges, does New Jersey have the money to do this work on its own? And what's the fiscal situation in New Jersey that relates to that?
Well, I don't believe that we have the money to do it on our own, and I think early in my testimony we described the level of federal-state partnerships that have always been successful when run properly and really in good coordination have always made sense. Having a one-size-fits-all exchange model that would be implemented by the federal government, I don't think would work in New Jersey, but be that as it may, in terms of the dollars and cents, we don't have the resource to implement, not only design, but also implement the exchange. And of course, our condition economically is as bad or worse than most other states, the worst recession since the Great Depression. And so our resources are limited, and already it is that the governor has decided that he's going to eliminate and reduce programs to the uninsured, to the Medicaid recipients in our state. So I don't see how it is that New Jersey, or any other state for that matter, unless they find a pot of gold, can come out from underneath this recession without the partnership of the federal government.
Well, I appreciate that. Let me ask you about the prevention and the Public Health Investment Fund, because, again, we're trying to provide Americans with better choices about prevention. Both Democrats and Republicans keep talking about prevention as a way to provide better quality care and save money. And I think, if you talk about where we are today before this act, the health care reform goes into place, be more apt to describe the situation as sick care rather than wellness care. And that's why we created this prevention fund, to provide Americans with options to keep themselves healthy instead. There are over 530 organizations that support the Prevention and Public Health Fund because it's already shown it can deliver on the promise of creating a better pathway to prevention. So many people on both sides of the aisle have supported prevention because it holds a promise to reduce health spending. And I know this has been important to you, both improving health and reducing spending. My question, Senator, again, is New Jersey has received over $15 million in grants from the fund. It's supported activities such as quit lines, HIV prevention, other important activities. Are you able to comment on how prevention and public health fund awards like these help to complement your own state efforts? And is this an investment that's worth making? Because obviously the Republican option is to eliminate it.
Well, if we look at, and I think everyone in this room will agree that we want to have smart public health opportunities and options for every American, but states can't go it alone, but we also know that it makes smarter financial sense to address these issues early on in terms of prevention, not only in terms of primary care prevention, spending money in the beginning of life on prevention and not at the back end of life, but also on all the public health initiatives that the federal government and the state government by itself provides. Certainly lowers cost, lowers the instances of contagious disease and infections, and all the variety of things that happen to people in the public health field. And so reducing those costs is paramount, and so that makes financial sense. We're going to spend so much more on not treating on wellness, but on sickness, as you said earlier, as opposed to spending it up front. It makes sense to spend it now and do it in a way that's appropriate and provides the greatest bang for the buck.
I appreciate that. I don't want us to be fooled by these arguments about mandatory versus discretionary spending. In this fund, 71% of Americans favor increased investment in community health and disease prevention. I think it's tragic that we're even considering striking the fund, given what it can do. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Gentlemen's time has expired. Chair recognizes the Vice Chairman of the committee, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Goodman, did you want to respond to that last question?
I agree with Congressman Pallone that both Republicans and Democrats are out there saying that by spending money on preventive care, we will save money overall, but it's just not true. There are an enormous number of studies of this issue. They overwhelmingly show that preventive medicine, by and large, does not save money. That yes, you'll save money if you catch a disease in its early stage with one person, but to get to that person, you have to spend money on 10,000 other healthy people, and it turns out that there are very few preventive procedures that actually save money. I think the political reason why we hear so much about preventive medicine is it's the only thing you can do for healthy people, and most people are healthy. So it makes political sense to talk about spending money on preventive care, but it is not a way to overall lower health care costs. Pregnant women at risk, smoking cessation advice, immunizations, they will pay for themselves. But giving free checkups to the elderly, that will never save money.
Interesting observation. And we do appreciate all of you being here. Let me just say that again. Mr. Vitale, let me ask you a question. In your testimony, you talk about the rollback of the funding of the country's school-based health centers and maintain that, in fact, that is short-sighted. I don't know. You may be being a little tough on the president, but let's explore this a little bit. In the bill, law, as it is now, Section 4101A, the mandatory funding that we're talking about today is actually for school-based clinic construction, correct? Is that yes? That is a yes. Okay, clerk?
Yes, yes.
Well, no, that's a yes. What about the money for the doctors and nurses that are going to be in the clinic? Is that mandatory or discretionary?
I'm not sure.
Well, 4101B is discretionary. Mm-hmm. Do you know the dollar amount that President Obama requested in his latest budget that he sent up here to the Hill just a little over a month ago?
For which part of it?
For the staffing of the school-based clinics.
I'm not aware of it, but any staffing will be helpful. If the money doesn't exist in that proposal, then it is what it is. But what's important to recognize is that, whether it's for bricks and mortar or whether it's for individuals to serve in that capacity, in those capacities, is vitally important.
Let me ask you a question. What is the value? Well, the actual dollar figure requested by the president was zero. Mm-hmm. So I think maybe you're stating the president was short-sighted with that budgetary amount. I don't know. I'll leave that up to you. But what good are the bricks and mortar if you don't have the doctors and nurses there to receive the children, the patients, when they come in to be seen? Well, how are you going to have a child seen at his school site if there's no doctor or nurse in the clinic?
Well, the elements of reform and PPACA and what we do in New Jersey is to encourage primary care workforce development. So
you encourage it by not funding it in the discretionary part of the president's budget, and that is a discrepancy, and that's one of the things that the secretary couldn't answer the question when I asked her why it was that it was constructed like that. I'm going to accept that it was a drafting error on the part of the Senate. I'm going to accept the fact that this bill was a poorly constructed product that was rushed through on the Senate floor to get the senators out of town before a snowstorm hit on Christmas Eve. We all accept that. They never got to a conference committee because we know that 2 weeks later Scott Brown gets elected. They lose a 60-vote margin. Nancy Pelosi said there's not 100 votes for this damn thing over in the House. And it took 3 months to twist enough arms and crack enough skulls to get it passed, and that's precisely the reason why, because it doesn't deliver on the promise that it was intended. Now, another aspect is, what is the duplicative aspect of this? You had a stimulus bill that passed in February 2009, $3 billion, I believe, for community health centers. Was there not enough to scrape together for the $50 million that would fund the school-based health clinics in this program? Did you have to fund it? Did the Congress have to fund it twice to get to your level of satisfaction?
Well, I would certainly welcome and support legislation that you could introduce that would fund those programs and put those doctors and nurses in those buildings.
Well, okay, now here is the other part of the problem. Last month, $223 billion overdraft by the United States Congress. If you multiply that out over the 10-year budgetary window, that's almost $27 trillion. That's twice what the debt limit that is going to be expanded later this year. That's twice what the debt limit already is, and that's irrespective of any money collected in taxes. So that is the problem. There is no money there, and that is an important concept. Now, let me just ask you a question. Governor Christie, did he sign on a letter asking for relief of maintenance of effort to the Congress?
Yes, he did.
And was he correct or incorrect in that regard?
He was incorrect, sir.
I believe he was correct. And again, the answer is $223 billion overdraft. It is unsustainable. Mr. Chairman, thank you. I hope we have time for a second round because I have some questions of the other witnesses, and I'll yield back.
Chair, thanks, gentlemen. The gentleman's time has expired. Chair recognizes the ranking member emeritus of the committee, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, I thank you for your courtesy to me, and I want to welcome our panel, particularly our old friend, Mr. Ishtook. I'm delighted to see you here, Vern. I am troubled about the committee and what it is doing. I'm very much troubled that instead of trying to improve the legislation, we're concentrating on trying to repeal it. At the same time, I note that those who would repeal the legislation and who are trying to impede the implementation of this legislation are coming forward with no suggestions as to alternatives and no differences that they would make because of either amendments or replacement legislation. And now, this is a yes or no question, old friend. You have great familiarity with the differences between mandatory and discretionary funding and the importance of both. And I know my colleagues have concerns that they've expressed about mandatory spending under the Affordable Care Act. But I would point out that the majority of the members on the other side of the aisle have voted for this kind of funding when it suits their purposes, particularly in the instance of the Medicare Part D or the Medicare Prescription Drug Improvement and Modernization Act. There was a lot of funding of this particular kind. And a similar situation where many of the members on the other side of the aisle also voted for the S-CHIP program in the Deficit Reduction Act. Would you agree, old friend, that mandatory appropriations are from time to time a necessary part of legislating, and particularly so in the case of the Medicare Prescription Drug Improvement and Modernization Act and in the Deficit Reduction Act, yes or no?
Well, I always appreciate your courtesy, Mr. Dingle. The challenge is there are different types of mandatory appropriations. They have been used in different mechanisms. I've never seen them used in the same way that they are here. For example, in the prescription drug benefit bill, you had an existing program which receives permanent appropriations, namely Medicare, and there is an expansion of its scope rather than a creation of a new mandatory stream of funding.
But we are following a precedent long established in many different instances.
I don't see it in the manner it's done here, but I know that's your point.
As a former member, you served here with distinction. Do you agree that Medicare and Medicaid programs are essential cornerstones of the health care system in this country?
I think they certainly have become cornerstones upon which people depend. Is it necessary, especially for Medicaid, to be its current scale? I don't believe so.
And those two bills, as we have been discussing, have been funded by mandatory appropriations over the years. Well, I want to thank the panel for being here. I notice I have 1 minute and 27 seconds, and I just want to maintain that I continue to appeal to my friends on the majority. Let's work together to get a good piece of legislation made better and to meet the concerns that are expressed by all of us here about different components of this legislation. I've heard that the members on the other side want to repeal it. I think that would be extraordinarily unwise, and I would hope that they would join us in trying to improve our nation's public health, to save our health care system, to see to it we have the money in the system that we need, and that we have a workable program that will head off the appalling increase in cost which we see going forward on a continuing basis under the old system. And I thank you for your courtesy, Mr. Chairman.
Chair, thanks, gentlemen. Gentleman's time has expired. Chair recognizes the gentleman from Ohio, Mr. Latta, for 5 minutes for questions.
Thank you very much, Mr. Chairman. Appreciate it. And to our panel, thanks very much for being here. Greatly appreciate it. It's always enlightening to get the testimony from you all. Dr. Goodman, if I could maybe start with you. Kind of interesting because I know that this was discussed a lot during the debate on the health care legislation. On page 7 of your testimony, when you were talking about Massachusetts and what's happened up there. You said, interesting that you stated that people remain uninsured while they are healthy and get insurance after they are sick. then they receive care and their medical bills are paid, they drop their insurance coverage again. And I guess some of the questions I'd like to ask is, first of all, what's the enforcement mechanism they have in Massachusetts, or lack thereof, to try to change this or get people to be on insurance all the time?
Well, the Massachusetts model has a fine, and the general Massachusetts approach was copied. I do agree with President Obama on this. The federal model did, in large part, come from Massachusetts. And it's a strange model because, in other health care programs that we have, we don't let people game the system. In Medicare Part B and Medigap insurance and prescription drug, you don't let people just go until they get sick and then sign up for the same price everybody else is paying. There's a penalty if you do not sign up when you're eligible. And yet in Massachusetts, people can wait until they get sick. They can sign up at any time. There's a 12-month open season. They pay a small penalty when they're not insured, but the penalty is small compared to the cost of insurance. So the real incentive there, and the real incentive under the Affordable Health Care Act is go bear while you're healthy, pay the fine, and wait until you get sick, and then sign up for the most generous. If you're really sick, you'll sign up for the most generous of the options that you have.
Do you know what that penalty is, out of curiosity?
In Massachusetts, I don't remember, but under the Affordable Health Care Act, it will be less than $1,000 a person.
This might be a rhetorical question then, because I already know what the answer is. Who makes up that difference?
Well, the cost of the care falls on everyone else, and if you allow people to game the system, stay outside when they're healthy, let them join when they're sick for the same premium everybody else pays, premiums have got to rise. Everybody else has to pick up that difference. And through time, costs just get higher and higher and higher as people are allowed to game the system in that way.
Thank you. Congressman, a question for you. As a former appropriator, when you look at this, and you stated in your testimony, but is it right that Congress should really abdicate its responsibility by saying that we're going to have these going out year after year after year in these mandatories instead of us looking at it every year? Because we, as Dr. Burgess pointed out, that we had a $233 billion shortfall in the month of February. Should that be abdicated by Congress?
No, neither in the case of Obamacare, nor for that matter in the case of Medicare or Medicaid, should we have unrestricted, open-ended appropriations or permanent appropriations, rather than putting things upon a defined budget that is defined by what Congress is able to provide, what the nation can afford at a particular time. So this is a common problem with any form of mandatory appropriation, whether it be the permanent appropriations that go out, for example, to Medicare, or the different process that was used here, passing a series of annual appropriations for 10 consecutive years. Either way, you're not matching your current resources with what you're trying to provide. And that, of course, is what leads to deficits such as the $1.6 trillion that we have for this current fiscal year.
Thank you very much. And if I could, I'd yield the remainder of my time to Dr. Burgess.
Thank you. Dr. Goodman, you mentioned in your testimony that the mandate is going to become ever more costly. Already alluded to the amount of money the deficit is for February of this year and what future projections are. How expensive is that going to be for the taxpayer in the years ahead?
Well, I don't have an estimate off the top of my head, but it's going to be very expensive, and it's going to be more expensive than I think the Congressional Budget Office has estimated. And the reason is because of these different subsidies that I've talked about. It's going to be foolish for moderate income employees to try to get insurance from an employer. They're all going to find their way into the exchange, and the subsidies in the exchange are paid for by the federal taxpayer. So I think the Congressional Budget Office was estimating maybe 17 million people would go over into the exchange. Douglas Holtz-Eakin, former director of the Congressional Budget Office, thought it might be twice that many, but it could be much higher than that. I think eventually everybody who can get a better deal will be in the exchange.
The gentleman's time's expired. The chair recognizes the gentleman from New York, Mr. Engel, for 5 minutes for questions.
Well, thank you, Mr. Chairman. I'd like to first ask unanimous consent to introduce for the record a letter from the public health commissioners from 10 of our nation's biggest cities, which provides great examples of the ways the fund is being used in our nation's cities.
Without objection, so ordered.
Thank you, Mr. Chairman. Mr. Chairman, Republicans have decided that this is the week to talk about mandatory spending in the Affordable Care Act. This has probably confused many Americans who thought that Congress was going to focus on creating jobs and reducing the deficit. I want to welcome our three panelists. I want to welcome Congressman Istuk back. But let's examine the issue of the Affordable Care Act's mandatory spending provisions. One of our colleagues, Michelle Bachmann, on Meet the Press last weekend, said that using mandatory funding was, quote, unquote, gangster government. And she said that this mandatory funding was the bill's, and again I quote her, dirty little secret. Congressman Istuk, you said to factcheck.org that this assessment was fair because these appropriations were, quote, and I quote you, not trumpeted loudly by sponsors of the measure, unquote. So I'm going to ask you in a minute to comment, but let's review the history here. For example, let's look at the Prevention and Wellness Fund. This is a critically important fund to provide stable funding for our public health infrastructure. The fund will support state and community efforts to prevent disease and make our nation healthier. Over 530 organizations have supported this fund because investing $10 per person per year on community-based prevention could save this nation more than $16 billion annually. I've never considered this a dirty little secret, quote unquote. I'm proud of it. I've tried to trumpet it loudly. It was in just about every document we ever produced. Every draft on the House and Senate side, every explanatory fact sheet, and every full CBO score. So let me read to you from our fact sheet. Quote, provides $15 billion in mandatory spending to support prevention and wellness activities, unquote. Does that sound like we're trying to keep this a secret? Even a fact book, factcheck.org, concluded that, quote, no secret, Bachman gets it wrong, unquote. And the Washington Post said, quote, this is bordering on ridiculous, and concluded that there is no bombshell beyond the bombast. But let's take this chance to learn more about the fund. I'd like to first ask Senator Vitale, according to healthcare.gov, organizations in New Jersey have received nearly $15 million in prevention and public health grants, from tobacco cessation programs to HIV prevention to public health infrastructure to primary care training. Senator, you mentioned in your testimony the idea of bringing primary health care services to people in their behavioral mental health setting. I'm told that people with serious mental illness die an average of 25 years sooner than the general population, largely due to untreated chronic disease. Can you tell us how bringing primary care and mental health together is actually an important shift in how we think about prevention?
Well, thank you for the question, Congressman, and you're right. It is an incredibly important way in which to bring the care to them. I think that, for a long time, a lot of policymakers, even state legislatures, have overlooked the importance of those mental health and substance abuse issues. And, in New Jersey, we have the same issues. And I was a little blindsided or dumbfounded by a comment by my friend Dr. Goodman that prevention really doesn't save money. I talked to any other healthcare expert in the nation that is learned as he is, that we would get a different answer. That prevention model is incredibly important. It means the world to people, even in terms of life and death. And so I would support those initiatives, and they make a whole lot of sense.
Thank you. This fund is much more than simply providing more funds for good things. It's about changing the way we think about prevention. I can't think of a better use of tax dollars than to institute proven prevention strategies that could save the taxpayers money. I just wanted to say, Dr. Goodman, not necessarily need a reply from you, but I was interested in your talking about the Massachusetts bill vis-a-vis the bill that we tried to put in. And I think you actually make a point many of us have been saying, that the fact of the matter is it's not fair for someone not to belong and then when they get sick opt in, because then everyone else's premium rises. That's why you have to have everyone being directed to mandatorily purchase insurance. And I find it really ironic that Mr. Romney, who implemented as governor the law in Massachusetts, which allows people to first get sick and then opt in, is now one of the people who's cracking the bill. Mr. Istuk, I want to give you a chance to respond. You replied to an inquiry from Fact Check that Congresswoman Bachmann's dirty little secret remarks against the government was fair, and you said these appropriations were, quote, not trumpeted loudly by sponsors of the measure. I tell you, we trumpeted it loudly, and I don't know, why you can say that we tried to hide it, but I'd like to give you a chance to answer.
If I may, Mr. Chairman.
Proceed.
Thank you. Actually, particular things have been checked both by Fact Check, by the Washington Post, and by PolitiFact. None of them had any criticism of what I have said on this. They had criticism of Ms. Bachmann, but not of my characterization. As I said, her characterization, I believed, was a fair comment and opinion. Just because something is well known to some people, such as yourself, does not mean that it has overall been well communicated to the American people. That is why I mentioned that we have a 2,700-page bill that is a huge haystack with a lot of needles still being discovered within that haystack. And I think the revelations are continuing, and that's part of what the chairman is seeking to point out during this hearing.
Thank you, Mr. Chairman.
Gentleman's time has expired. Chair recognizes Mr. Lance for 5 minutes for questioning.
Thank you, Mr. Chairman, and good afternoon to you all. I'm new to this committee, and it's my honor to meet for the first time Congressman Istuk and Dr. Goodman. I certainly know Senator Vitale. We served together in the State Senate for the 7 years I was in the State Senate. I believe Senator Vitale is completing his 14th year in the State Senate. And not only is he an expert on health care, he and I served together on the State Senate Budget Committee and worked on many issues together. As a general matter, the National Governors Association, in writing our leaders, Speaker Boehner and Leader Pelosi and Leader Reid and Leader McConnell in January, said that moving forward, Congress should not impose maintenance of effort provisions on states as a condition of funding. This was a general letter, and it did not relate specifically to the health care bill. It was more general in tone. I want to make that clear. I would like to have unanimous consent to introduce that letter into the record. It was signed in a bipartisan capacity by the chair and the vice chair of the National Governors Association.
Without objection, so ordered.
Thank you, Mr. Chairman. And then more recently, Governor Christie wrote the chair of the full committee, Chairman Upton, on March 1st, related specifically to the health care legislation. Governor Christie was unable to join the distinguished panel last week that included the governors of Mississippi, Utah, and Massachusetts. And as it relates directly to the health care issue, the governor of New Jersey stated that we in New Jersey are facing an unprecedented Medicaid shortfall of approximately $1.3 billion in state fiscal year 2012. And he goes on to state that our options to close this gap are severely affected by further restrictive maintenance of effort requirements in the health care legislation. Noncompliance with those requirements could result in our losing $5.4 billion in federal funding. Governors need flexibility, not federal mandates. To the panel in its entirety, if you would, gentlemen, beginning with you, Congressman Istuk, address your views regarding the maintenance of effort requirement, specifically given the fact that it seems to me so many governors have suggested that we should look at that. And, Mr. Chairman, might I place in the record of the subcommittee the letter from the governor of New Jersey to Chairman Upton on March 1st?
Without objection.
Thank you. Congressman Istuk.
Yes. Thank you, Mr. Lance. And having served in state government as well as federal government, I know that often states feel trapped by having gotten into a program and then told you have to maintain those efforts even if federal funding may be diminished or even if there are major changes in the federal program. A key example right now, the Obama administration is saying, oh, we're trying to provide states some certain opt-out flexibility, but what the fine print says is we'll only let you do it if we decide you're trying to do the same thing that we're trying to do. If you're trying to do things our way, it's not really an opt-out or not. It's still another level of control. So I fear that the maintenance of effort requirements have become just another way for the federal government to dictate to the states that they participate in a program that they cannot afford. Medicaid is the, if not the largest, certainly a enormous budget item in so many states right now, and they're finding that it's simply unaffordable, and providing some leeway on maintenance of effort is an important way to address that.
Thank you, Congressman. Dr. Goodman.
Well, of course, the states are trapped, and all the programs that we're talking about here today further trap people in the existing healthcare system. If we want lower costs and higher quality care, we have to let people get out of the way we have been doing things and try something new. Probably the best way that we could spend money on preventive care for low-income folks is to pay the market price that Minute Clinic charges in shopping malls and at Walmart for basic preventive primary care. At least I could argue that has a much better chance of getting care to people than anything else that we've talked about. And in any event, people at the local level need to have that flexibility, and these kinds of programs don't give it to them.
Thank you. Senator Vitale, my friend.
Well, you're right, Congressman Lance said the governor did sign on to that letter to remove that MOE from New Jersey's obligation, and I have to tell you that it could be the worst thing that could happen to that population. If this happened last year, when the governor cut out tens of thousands of parents from SCHIP, he didn't go below 133 because that was the maintenance of effort level. If he were able to do that this year, we would have tens of thousands of working parents who go to work every day without the ability to have health care and the access to health care that we all enjoy. He would also dismantle many of the benefit designs and programs in Medicaid to the age of blind and disabled and to a vulnerable population. So to say that the maintenance effort is a way in which the forces the states to provide their care, I know that at least in the case of our governor, he will take that opportunity to remove that care, and it would be just devastating for that population of literally hundreds of thousands of New Jerseyans.
Gentleman's time has expired. Chair recognizes a gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, Mr. Chairman. I just want to take a minute to clarify one item regarding the application process for construction funds. Already 350 community clinics or schools have applied for funding for construction. Part of that process includes the requirement that as they apply for the funds, that they demonstrate that they have adequate funding for adequate staffing for that facility. I want to also welcome our witnesses for their and thank them for their testimony, and in particular welcome to our former colleague, Mr. Istuk. As you all know, school-based health centers provide comprehensive and easily accessible preventive and primary health care services to approximately 2 million students nationwide. And there's no doubt about it, and I know this as many years of being a school nurse. Healthier children do better in school. At a time now when we're trying to out-compete and out-innovate other countries, we do need our kids healthy and in the classroom. Now, there's a statement, Senator Vitale, that I'd like you to respond to. See if you agree with this statement. It's a quote. School-based health centers have proven that effective preventive and primary care for medically underserved children can decrease academic failure rates resulting from poor health. Is that something you would agree with?
It is, Congresswoman, and thank you for being a school nurse. We have an example in the town in which I live, and I was interim mayor for a few months, and I worked with the Department of Human Services and the Visiting Nurse Association of Central Jersey to establish a school-based health clinic in 6 of our communities out of 30 schools, 6 of the most medically underserved schools in our school district, and one of which had a very high special needs population. And now, several years later, when I visit and we assess the efficacy of that program, it clearly illustrates that those children receive care when they need it up front, right in the school. Parents get the prescription. They're able to write those prescriptions because advanced practice nurses now can diagnose and prescribe. Kids get on their medication earlier. They get back to school quicker and they learn faster. And we have seen an enormous decrease in the amount of absenteeism for all those children in those 6 schools, where previously those absentee rates were much higher. So they're learning better, they're learning faster, and parents who need to take time off from work and in many ways don't have can afford to do that save that money as well.
Absolutely. I agree with your testimony. It's eloquent. I also agree with the statement that I quoted, and I wish I could take credit for the quote, but I wanted to point out that this comes from two of my colleagues who are members of this committee, Chairman Emeritus Barton and Mr. Burgess. And they sent a dear colleague highlighting their support, along with their fellow Texan Congresswoman Kay Granger, their support of school-based health records centers. And after an endorsement like that one, I find it quite puzzling that our Republican colleagues are here trying to eliminate funds for communities across the nation who want to benefit from the school-based health centers.
Will the gentlelady yield?
I'll yield after I finish my statement and question. In fact, the interest in expanding school-based health centers is so great that HHS has received 350 applications for this funding. Requests come from 44 different states, including the congressional districts of 9 of our Republican colleagues who are part of this subcommittee. So let's be clear, the need is there. While these centers benefit all children who have access to them, they are also a vital support for low-income Americans. And I hope it's clear to us all that 40% of children treated at school-based health clinics either have no insurance or are enrolled in Medicaid, S-CHIP, or other public coverage. For some children, school-based health centers are the only consistent access to health care that they or their families have. And we know there are millions of other children who could benefit from them. With more access to these centers, these children could be spending more time learning in their classrooms and less time clogging up our emergency classrooms. And now, Senator Vitale, as a former mayor, which you mentioned, and current state senator, you do understand the economic needs of local communities during these tough times. The funding for school-based health clinics instruction is the perfect shovel ready for today. So with so many people out of work, we're trying to provide more jobs for the American people. Maybe you can talk about what this means to your state of New Jersey.
Well, we have many of the same challenges as every other state. In fact, New Jersey being so urbanized in so many areas and where there are so many medically underserved populations, school-based clinics are a perfect way to capture kids that are school age. Providing the bricks and mortar, the dollars for those bricks and mortar are certainly very important, but the other elements of the bill, of the act that would help us to train additional physicians, advanced practice nurses, to put those bodies in those clinics from time to time is also an important element. So we're dealing with both the bricks and mortar and those who would be, future physicians and advanced practice nurses. So those two elements combined certainly make great sense and will make a great deal of difference in urbanized communities.
Thank you. I wanted to yield time to my colleague, and I would be happy to, but could I ask unanimous consent, Mr. Chairman, to insert 2 letters for the record, one from the Sex Education Coalition and also one from the American Nurses Association. These groups highlight the importance of personal responsibility education program and of school-based health center. And I think for the record we should also include the the dear colleague that was sent out by our colleagues.
Reserving the right to object until I have a chance to respond.
All right, gentlelady's time has expired.
I object to the insertion in the record.
All right. He hasn't seen it, I guess.
Chairman,
can I
ask why
would you provide us a copy so we can look at it?
I have a copy. The copy is not the issue. I asked for a chance to respond. I was denied that chance. I will object to the insertion. I will object to the insertion of the record until I'm given such chance to respond. Mr. Chairman, I ask unanimous consent for 30 seconds to respond.
All right. Without objection. Without objection, go ahead. You can have 30 seconds.
The issue is not whether or not Chairman Barton and I support the program. The issue is to have mandatory funding for the construction of the clinic and zero funding for the doctors and nurses who staff it. The other issue is a $223 billion structural debt for the month of February. There are going to be all kinds of programs that I support in the past that we simply cannot fund. We simply cannot pay for everything. This is a poor drafting, a poor crafting in the bill that was signed into law a year ago. We should fix it. It's within our scope to do so. Let's make the construction an authorizing program, not a mandatory program, and I'll yield back.
Has the gentleman withdraw his objection?
Objection withdrawn.
All right. Without objection, then the letters are entered into the record. The chair recognizes the gentleman, Dr. Cassidy, for 5 minutes for questioning.
I forego my questioning. I wasn't here to hear the testimony, and although I have a great interest in the topic, I don't want to just read something put in front of me. I would actually rather digest. And so if I could yield to anyone who wishes to have time yielded to them. But
I'd be happy to accept the time from the gentleman from Louisiana. Dr. Goodman, we started just a moment ago when I had a few seconds yielded to me, and we were talking about the costs of the subsidies. Now, we had multiple hearings leading up to the passage of PPACA a year ago, and one of the things that got me was we never really focused on the cost of delivering care. Now, you have been a proponent of patient power, consumer-directed health plans. Governor Mitch Daniels in Indiana popularized the Healthy Indiana program, and over the same period of time that Medicare and Medicaid expenses, PPO expenses, grew by 7 or 8%, he saw an overall reduction in expenses for state employees of 11% over that same 2-year interval. Would you care to comment on the techniques used by Governor Daniels to hold down costs in his state with his state employees?
Part of the approach is to empower patients and give them control over dollars, and that's the reason I said earlier, if low-income families could just stop by the Minute Clinic, get their immunization shot, get their flu shot, get prescription filled, that probably is a better use of money than building a lot of buildings.
And what is the barrier to the patients doing that?
The barrier is that governments and bureaucracies control all the money, and it's not patient-friendly. And so the system is set up so that it's a relationship between the provider and the payer, and the patient is just the excuse to bill. And if you want real change in the marketplace, then you have to have providers competing for patients based on price and on quality. And they're not going to do that unless the patient controls the money. I wonder if I might respond to to Congressman Inkel's point about Massachusetts and the mandate there, if I may, because I've talked to Governor Romney about this. They did it the wrong way in Massachusetts, and we did it the wrong way in the Affordable Care Act. And if I could just choose a number, suppose we're willing to offer somebody a $2,500 subsidy to buy individual health insurance. The way to do it is to offer it as a refundable tax credit. So if he buys his insurance, he gets his $2,500 for the insurance. But if he doesn't buy the insurance, then the $2,500 needs to go over into the social safety net. So if he goes in for care, he doesn't have insurance, he's responsible for his bills. If he can't pay for his bills, we put money over there for him. But in doing it that way, you don't let people game the system. You let money follow people. We'll never get all the people in the insurance system. But the way you make them pay their own way is they pay higher taxes if they turn down your subsidy. And that's the right way to organize the system. And I can't speak for Governor Romney, but I think these days he's leaning more toward that approach than trying to force everybody to buy a plan that they don't really want to buy.
Thank you. Mr. Ishtuk, you were an appropriator during the years that the Medicare Modernization Act passed. Would you care to comment on on some of the discussion we've heard today, how the forward funding or advance appropriations occurred in the Medicare Modernization Act? I was too young to remember it or to acknowledge it at the time, but you were there, a seasoned appropriator.
It was not done the same way. What we have in Medicare, whether you're talking about Medicare Part D or any other Medicare, you have what's called a permanent appropriation. Now that is a problem, because rather than having a defined amount where we spend what we can afford to spend, it's an open-ended expenditure. So when Medicare Part D was created, it was simply changing the definitions of what's covered as opposed to providing new appropriations. In the case of PPACA, Obamacare, there are a series, and the Congressional Research Service devotes, I think, 16 pages to describing specific item after specific item after specific item after specific item where they make appropriations for the current fiscal year when it happened, FY10, where they make appropriations that are explicit to FY11, explicit appropriations for FY12, and so forth, all the way up to fiscal year 2019, scattered over a whole variety of different programs. So it is taking singular programs, and a great number of them, and creating annual appropriations for them, not on a permanent basis, but for a 10-year period, not changing the definition of something that exists that already has permanent appropriations. It's a very different process and very unprecedented in my experience.
Thank you. I'd just point out H.R. 3200 that passed this committee, the appropriation, the public health fund was subject to appropriations.
That's
now
the norm.
Thank the gentleman for yielding. I'll yield back.
Gentleman's time has expired. Chair recognizes the gentlelady from Illinois, Ms. Schakowsky, for 5 minutes for questions.
Thank you. First, I wanted to clarify something about the school-based clinics. The grant application for the school-based clinics, which many schools are applying for, is very clear. They need to demonstrate that the funds, that they have the funds to run the center, but they don't have the funds to build the center. So this is a situation where denying construction funds actually would deny the clinic, and they understand that they have matching, that they have to provide the money to run it. Mr. Estruk, we are kind of getting into the weeds here, but in general about this issue of secret funding, you said that fact check, exonerated you, but I wanted to just read a quote. You said that it's within the range of fair comment and opinion for Congresswoman Bachmann to say that funding for these and other programs was a secret. So in a way, you're saying that this kind of, we didn't know about it, nobody knew about it, this was snuck in there, is a fair statement. Do you agree with that?
Well, when the Speaker of the House told people that you had to pass the bill so that folks could find out what was in it, I think that illustrates that
in this
thing we're finding out bit by bit is certainly within a realm of fair comment. Yes.
So even though the debate was very clear, for example, on the CHIP program, you say that there's something very different about the Medicare Prescription Drug Improvement and Modernization Program, which you voted for. But in fact, $40 billion of what's in the the Affordable Care Act goes to the CHIP program just for 2 years. So isn't that exactly the same thing?
Actually, it goes for 2 years, and those particular 2 years, if I recall correctly, are something like adding, 2017 and 2019?
No, 14 and 15, actually, and that's when the program goes into effect.
There are other provisions that go up to 2017.
Well, I wanted to ask you about something.
So that's the point there is, if something is supposed to be subject to the annual appropriations process, why isn't it subjected to the annual appropriations process by the people?
Well, that's what I want to ask you about. Funding for the State Pharmaceutical Assistance Program into 2006. That was 3 years into the future. You voted for that, right?
I'm not sure what you're talking about.
Well, this was in the bill.
Okay.
A 3-year appropriation for the State Pharmaceutical Assistance Program, and there was also funding for a pilot program for nursing home background checks. That's 4 years into the future, and of course that was a good call, but you voted for that.
Ma'am, one, if you have specific provisions you want to recite from that bill to see whether they're parallel, I'd be happy to look at that. But secondly, whether you're talking about the practice of advance appropriations for appropriations that occur 1 year or 2 years in the future, there is no comparison with a bill that seeks to make advance appropriations 10 years in the future, which is what we're talking about with Obamacare.
When you voted for the Personal Responsibility and Work Opportunity Reconciliation Act of 1996, the welfare reform, did you know that that bill contained significant mandatory appropriations for abstinence education and child care and development block grant?
When you use the term mandatory appropriation, means different things. Did it have express line items for year by year for fiscal years? Do you have that information in front of you?
Well, let's ask for the Deficit Reduction Act, but you missed that vote. But all the Republicans on this committee supported it. It contained mandatory spending.
Well, again, you see, the term mandatory spending is used to cover a lot of different definitions. I'm talking about the practice of advance appropriations, which are defined, and this is from OMB, which are defined as one made to become available 1 year or more beyond the year for which the Appropriations Act is passed. That is not the same as other categories of so-called mandatory spending. It's certainly not the same as permanent appropriations as are found, for example, in Medicare. So, again, if you have something specific you'd like me to look at, the line item of a legislation, But I find nothing that's comparable to what happened.
Well, actually, that's not true, because the state pharmaceutical assistance program that you asked about, and I was listening to you while staff was telling me, that was unlimited into 3 years in the future, but absolutely unlimited. There was no dollar amount.
Recite well, then it's certainly not the same thing as what we're talking about if you say there was no dollar amount. If you have a citation to a specific section of a law that you want me to look at, I'd be happy to look at that with you.
And let's remember also that none of this was paid for, period. That there was that legislation was not paid for at all, and the Affordable Care Act is.
40% of all federal spending right now, surely you can't say it was paid for.
The gentlelady's time has expired. Chair recognizes the gentleman from Illinois, Mr. Shimkus, for 5 minutes of questions.
Thank you, Mr. Chairman. Welcome to our panelists. Appreciate you coming. I'm going to yield my time to Congressman Burgess for questions.
I thank the gentleman for yielding. You know, it's almost like a line from that Kevin Costner movie, if you build it, they will come. So, okay, we're going to build the clinics. We're not going to fund the staffing, but the requirement is that you have to staff the clinic if you're going to apply for the building fund. But what happens when the states get into a budget crunch? Who could believe that that would ever happen? But it could. The states get into a budget crunch and they can no longer afford that. The fact of the matter is we're going to continue to build the clinics. That spending is required in the Patient Protection Affordable Care Act. So it's duplicitous to say that, hey, it's okay to mandate the funding for the building of the clinics because people have to demonstrate an ability to staff. In fact, they don't. If they did, why have 4101B contained within the bill? Now, again, I will accept Secretary Sebelius's assertion that she doesn't know why those two sections were put side by side, 4101A and 4101B. I accept the fact that the bill was poorly crafted and poorly drafted. I accept the fact that even though I opposed H.R. 3200, it was an infinitely better crafted product than this thing that came out of the Senate on Christmas Eve. After all, 3200 had a severability clause. The bill that was signed into law contains no such clause, and in fact, if there were a severability clause, we might not be having the arguments that we're having down in Florida today. Dr. Goodman, I wonder if you would, we heard it expressed again today that the Patient Protection Affordable Care Act is going to save $142 billion over the lifetime of the bill. I think that's preposterous, but you started to talk about the cost of the subsidies for purchase of insurance in the exchange. We've already talked about the huge deficit for the month of February, the extrapolated deficits into the future. What's going to happen to those projections when the subsidies for families earning up to $80,000 a year, what's going to happen when those subsidies kick in to the overall cost of this legislation?
Well, it's going to soar. So we're sort of treading water right now. There are a few changes that have been made, but really everything begins January 1st, 2014. That's when the mandates become effective, the subsidies become effective. Over on the employer side, I think that companies like McDonald's and Burger King, who employ a lot of workers who only make $10, $15 an hour, they are not going to be able to afford family coverage that costs as much as $6 an hour. So they're going to have to find a way to get their workers over in the exchange. And I don't know how they will do that, maybe treat them all as independent contractors, but they're going to find a way or they won't survive. And then when they get over there, the taxpayer is going to pay for not just the premium, but going to reimburse those workers for a lot of out-of-pocket costs. The costs are going to be quite large. Remember, the only way we're really paying for most of this is by thinking we're going to cut Medicare. But when you all, 3 years from now, start getting calls from seniors saying we can't find a doctor who will see us, then you're going to be under enormous pressure to undo all of that spending that's in the bill. And then you're going to find that you really haven't paid for this at all.
And, of course, the Independent Payment Advisory Board is beyond our scope today, but it should be the subject of a future hearing. But that actually has some pretty dire consequences. Again, wasn't part of the House Bill 3200, but certainly is part of the bill that was signed into law. Have you had any thoughts looking ahead of that Independent Payment Advisory Board and how that is supposed to structurally pay for the expansion of all of this?
Yes, and let me just say, too, that I think we do need to reform Medicare, and there is a right way to reform it. And the right way to reform it is let doctors and hospitals come to Medicare and propose different ways of being paid. If they can save Medicare $1, you ought to be able to let them keep 50 cents or 25 cents. And if you did it that way, I think you'd solve a lot of problems very quickly. But the only way this payment commission is going to be able to control costs is just by squeezing the providers. It's the only thing they know how to do is just squeeze down the doctor fees, hospital fees. And as the chief actuary of Medicare pointed out, the Medicare rates are going to be down here, and everybody else's rates are going to be going like that, and the difference is just going to go wider and wider through time. And by the time we get to the end of the decade, doctors will prefer Medicaid patients to Medicare patients. The waiting lines are going to be long, and seniors will be at the end of the line.
And what's the implication for the average member of Congress on that day?
You're going to be hearing from a lot of older voters, and they're not going to be happy.
I was going to say, are they going to be happy or sad?
They're going to be very sad.
I thank the gentleman for yielding his time, and I'll yield back the 10 seconds.
Chair, thanks, gentlemen. Gentleman's time's expired. Chair recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes of questioning.
Thank you, Mr. Chairman. I would like to draw attention to a statement from Senator Harkin, which I'd first of all ask unanimous consent to put into the record.
Without objection.
He's chairman of both an authorizing committee and appropriations subcommittee, and he says, quote, "I understand the implications of this guarantee that Congress should mandate appropriations for certain programs in the Affordable Care Act that are fundamental to its success." So I thought he has a lot to say from both sides of authorizing and appropriating. The health insurance marketplace was broken, and reforming the health insurance market was imperative. We say this frequently, and I'd like to ask rhetorically, what does it mean? It meant the number of uninsured Americans would have grown to 66 million by 2019. Those would be unhappy people as well. From 2004 to 2007, 12.6 million adults, 36% of those who actually tried to purchase insurance in the individual market were denied coverage. They weren't happy about that. They were charged a higher premium rate or discriminated against because of pre-existing conditions. Health insurance premiums more than doubled in the last decade and have risen 3.5 times faster than wages during the same period. In at least 42 states, at least 75% of the insurance market was controlled by 5 or fewer insurance companies. This type of market concentration provides a little leverage for consumers to fight insurance company abuses such as rescissions of health care coverage when someone gets sick or denials of medically necessary treatments are insisted on. Now, I might just point out that those facts are, I guess, the Republican plan, because they want to repeal the Affordable Care Act, which would leave us with the status quo. They would do nothing. The Affordable Care Act addressed these problems, and here are a few of the examples. They prohibit insurers from denying individuals insurance or charging people more because of pre-existing health conditions, from hangnails to heart disease. Limit out-of-pocket spending for health care benefits. Prohibit annual and lifetime limits by insurance companies. Significantly reduce red tape. Invest in ways to reform the delivery system to provide better care at lower costs. Senator Vitale, can you describe why health reform is so important, why repealing it would be disastrous for Americans, for the economy, and for our health care system?
Thank you, Mr. Waxman. This is, you all have a very difficult time of it here, and you made some very difficult decisions, very controversial decisions. I can speak from the experience in New Jersey and what it means to have a state with 1.3 million uninsured, mostly working people who get up every day, put on their shoes, and try to make a living and provide for their families. They work for small companies, by and large, who can't afford the cost of health insurance to provide to their employees. And if they can, the contribution by the employee is usually beyond what it is that they can afford. So the simple facts are, and setting aside all the controversy between what's mandatory and what's discretionary, the fact of the matter is that there are millions of New Jerseyans and millions of Americans who are suffering every day without an opportunity for what is reliable and dependable and affordable health care. PPACA provides that. It's an imperfect piece of legislation, and most legislative initiatives are, and I can speak for that firsthand in New Jersey.
Now, if it weren't there, we'd be back to the golden age of pre-Affordable Care Act, which I guess is what the Republicans would want. Now, one of the things they attack in this proposal today are the teaching health centers. For years, we provided mandatory funding for hospitals under the Medicare program to train medical resident trainees. In 2009, we provided about $9.5 billion in mandatory funding to train medical residents. Multiple expert bodies, including MedPAC, the Council on Graduate Medical Education, and others have called for more training of primary care residents and more training in the community, because that's where most physicians practice today. That's why the American ACA provided $230 million over 5 years to directly fund community-based centers to train primary care. My colleagues on the other side of the aisle have repeatedly called for more workforce efforts. One of the witnesses, Dr. Goodman, has criticized the ACA for not providing enough funding to train physicians. Senator Vitale, can you tell us about the importance of funding to train primary care residents in your state?
About 3 years ago, I attended a class and I spoke to a class at Rutgers Medical School, and there were about 60 students present. And I asked by a show of hands how many were going to be participating in, or going forward to primary care. One person raised their hand. So the importance is, of course, and thank you, Mr. Chairman, the importance is, of course, that we begin to develop this, not just those who practice in primary care, but also those who practice in advanced practice nursing.
Well, I can think of no better use of mandatory funds than to provide funding for residents.
The gentleman's time's expired. Chair recognizes the gentlelady from Tennessee, Ms. Blackburn, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our witnesses for your patience today, and also for understanding that we have another hearing going on downstairs. Mr. Vitale, I appreciate that you're here. I was a state senator in Tennessee before I came here, and I was a state senator during the TennCare era, which was the test case for public option health care. Now, I know in New Jersey you have guaranteed issue, and I think it's 45 mandates, am I correct, that you all have to cover in that package, which is pretty expensive. And the way TennCare is set up under an 1115 waiver with CMS, it was between the governor's office in Tennessee and CMS. So in New Jersey, do you all have any law on the books that allows the governor to spend state money without coming to the legislature?
Well, there are elements and we balance our budget every year by constitutional mandate. There are elements in the budget that is part of the governor's budget. And so he is, of course, free to spend the dollars in his budget appropriation.
Okay. Let me ask you this. The 45 benefit mandates, that's a big number. Do you think, as you're looking at the health care situation in your state and others and talking with us, do you think that individuals should have access to health care with fewer mandated benefits, state or federal mandated benefits?
I think we should all have the same benefits available to all of us.
So you think one size fits all? Is the route that we
yes,
should travel.
I
have to differ with you on that. Mr. Istuk, let me talk to you about the teaching centers. I found this very interesting. Section 5508 of Obamacare provides $230 million, not simply an authorization, but this is for the teaching study programs. Yet the president's budget zeroes out funding for children's hospital graduate medical education. And you're a former appropriator, so do you think that it is wise to make one program mandatory and beef up one and then completely cut out another one, especially when you're looking at children's health care?
There's an unfortunate trend that we have seen in the President's budget proposals of substituting mandatory funding for discretionary funding. In other words, trying to remove things beyond the ability of Congress to control spending. Examples include not only what you cite, but when the President says, for example, we're reducing discretionary spending, if you read the budget, you find that one way is you take Pell Grants and say they're no longer discretionary, now they're mandatory. You take transportation funding and say it's no longer discretionary, now it's mandatory. And they then trumpet a claim that we have reduced discretionary spending. Well, you've done that by relabeling it as mandatory. There's no savings there, and it's lousy practice as far as accountability.
And Mr. Goodman, Dr. Goodman, if I could come to you on that very point, because the concern of moving things from discretionary to mandatory is of great concern to us. As you all have reviewed the bill, have you been able to articulate the number of times that this has happened in the Obamacare bill and to look at the estimated impact above what we know as the appropriated dollars for this one action?
Well, not beyond what the Congressional Research Service report has stated. I just think there are, as my testimony indicated, fundamental flaws in this bill, and in response to the other to Congressman Waxman's critique, behind every flaw that we discussed in this testimony, we said this is the alternative. This is the right way to do it. As far as general concept is concerned. And if we don't do it the right way, then we're going to continue on a spending path that is simply unsustainable. There's nothing in the Affordable Care Act that fundamentally changes the way we're going to pay for health care. It's going to make all the perverse incentives that are now there worse than they were before, and the price we pay is going to be higher.
I found it so interesting last week, and I discussed this with Secretary Sebelius last week. There was a Wall Street Journal editorial where you had Ms. Cutter and Ms. DeParle. There was word was that they were telling people not to worry about all the numerous waivers that were there and not to worry about the duplications, that this is a way, giving the states the waivers was a way to ease us more to a single-payer system. And as we've looked at these programs, the Personal Responsibility Education Program, there's money for that is made mandatory in the Obamacare program, but yet the President's fiscal year budget, 2012 budget, includes $16 billion for programs that overlapped. Are you all doing any research work on that? And I know my time has expired, and I will yield back at the end of your response.
Well, let's think about what those waivers are about. 2.7 million people have been granted a waiver. That contrasts with 12,500 people who have the problem everybody's talking about, that they've been denied health insurance because of a pre-existing condition. 12,500 people now have been signed up for insurance, paying the same premium healthy people pay. That problem solved. The 2.7 million people are people like the workers at McDonald's who earn $10, $15 an hour. The insurance that they're going to have to buy for family coverage would be almost $6 an hour. They can't afford it. McDonald's can't afford it. That's why they were granted a waiver, but at the end of the waiver period, the problem is not going to go away.
The gentlelady's time has expired, and the chair recognizes the gentlelady from Wisconsin, Ms. Baldwin, for 5 minutes. Questions.
Thank you, Mr. Chairman. And before I turn to the topic of the hearing, I do want to express my gratitude to you and members on both sides of the aisle for advancing H.R. 525 on public health veterinarians, which passed last night by the very comfortable margin of 2 votes. So our mission accomplished with regard to that piece of important legislation, and I do really appreciate the efforts of members on both sides of the aisle. Turning to the subject at hand, many are familiar with the expression, everyone is entitled to their own opinions, but they are not entitled to their own facts. And I understand that my Republican colleagues may have differing opinions about the health care law that was signed into law last year, but there should be no mistake about the facts. The 5 committee prints that we are looking at in this hearing put forth by the majority will not create jobs. These proposals will not stimulate our struggling economy, and these proposals will not put the middle class of America back to work. The Republican majority is playing what I would consider a dangerous game of bait and switch with the American people. Despite promises from the new majority during the midterm elections that this Congress would be focusing on creating jobs and bolstering the economy, the legislative proposals and the committee prints that they have offered us today fail to deliver on this promise. In fact, not only do the majority's legislative proposals do nothing to create jobs or bolster the economy, I think these proposals would actually exacerbate the problem by taking away new job opportunities. With new investments in the health care law, we took tremendous strides towards expanding, for example, the primary care workforce. And we are on a path to train 16,000 new primary care providers in the United States. So far, my home state of Wisconsin has received $3.8 million for a primary care residency program. And we know how important training primary care physicians is for our economy. I mean, these doctors serve as gatekeepers, keeping people out of emergency rooms and controlling health care costs. The Republican proposal to change the Teaching Centers Development Grants program places this investment at risk and could ultimately worsen the healthcare workforce shortage. I fail to see how taking away funding for critical jobs is going to help our economy. Another proposal that we're looking at today would repeal funding for grants to states to establish exchanges. These exchanges are critical for ensuring that thousands of small businesses and 24 million Americans have access to new coverage options. The grants to states would provide states with the flexibility to create an exchange that meets each state's needs. Wisconsin has already received $38 million through an early innovator grant. This critical funding will spur job creation in my state and improve access to quality, low-cost health coverage. This Republican proposal raises an important question. Are we going to ask cash-strapped states to return the money they've already been awarded? Will Wisconsin have to return the $38 million that Governor Walker has already accepted? And I fail to see how rescinding money will create jobs, and that will create jobs is the right thing to do to get our economy back on track. Mr. Chairman, the American people, the people of Wisconsin deserve better, and we should be focusing on the greatest need our country has right now, which is jobs, jobs, and jobs. I would yield my remaining time to the gentleman from New York, Mr. Weiner.
Thank you very much, and welcome, gentlemen, particularly you, Congressman. It's so nice to see you back. It's nice to see people who leave this place with marketable skills. I'm glad at least you do. I just want to ask exactly. I just want to ask a yes or no question, if I could, in the brief time that Congressman Baldwin has yielded to me. Congressman Istook, is Medicare a single-payer system?
No.
Dr. Goodman, is Medicare a single-payer system? Senator Vitale, is Medicare a single-payer system?
I believe it is.
It is single-payer in the traditional way that it's used because there's one person writing the checks. But that doesn't mean that, right? I mean, there's basically the federal government collects our money in our taxes, in our payroll taxes, and then reimburses doctors, reimburses clinics, reimburses other. That's a single-payer system. It doesn't mean that Medicare employs the doctors, doesn't mean they employ the clinics, doesn't mean they employ the pharmaceutical companies. It is just who passes the money along. And in the 1 second I have left, you know what the overhead and profits is of Medicare? 1.03%.
Gentleman's time has expired. The chair recognizes the gentleman from Georgia, Dr. Gingrey.
Mr. Chairman, thank you, and Representative Istook, let me associate myself with Representative Weiner in regard to his comments. Thank you for your service, and proud to see you, and thank all three of the witnesses for your testimony today. I want to start out by saying that the actions of this administration and the Secretary of Health and Human Services, I think, border on deception, and they leave me with very little confidence in both Obamacare and the administration's ability to enact the law through regulation over these next 3 years. Just last week was the latest example. Secretary Sebelius, right here in this committee, told Congressman Shimkus that the administration was confident that she could spend one pot of money, $500 billion worth of money, twice, both to pay for Obamacare and increase the solvency of Medicare. And then next, the Secretary testified that she had used her powers as Secretary to slip in an end-of-life provider code into Medicare in the dark of night without allowing for public comment. And finally, she told our panel and a Senate Finance Committee panel a few weeks ago that a major long-term care program created in Obamacare that she is in charge of was totally unsustainable, but only after direct questioning. No previous announcement to the American people or to Congress, and of course I'm referring to the Class Act. With these thoughts in mind, I wanted to ask you, Representative Istook, Section 4002 of the Obamacare bill, Affordable Care Act, created a fund for prevention, wellness, and public health activities. In the language of Obamacare, it says that these funds are for, quote, sustained and national investment in prevention and public health programs, end quote. Are the words prevention and public health programs defined in Section 4002?
I'm not aware of any definition. I think that's left to the sole discretion and judgment of the Secretary.
And so conceivably then Secretary Sebelius or any secretary could use these funds for any purpose that they decide is prevention, correct?
Oh, yes, they could be extremely broadly defined.
Wide discretion on the part of the Secretary of HHS. And let me go to Mr. Goodman. We all remember the anti-Griffith Medicare ads that the Secretary ran last year that looked a lot like, to me, political advertising for the Affordable Care Act, Obamacare. Is there anything that would prevent the Secretary from using these taxpayer dollars to pay for similar political advertising on provisions in Obamacare and a lead up to the 2012 elections, as an example?
I don't think so. And let me say those anti-Griffith ads were extremely deceptive, bordering on fraud, because what he talked about were the benefits for seniors under the bill, but didn't mention any of the costs. And for every $1 of new spending, there are $10 of reductions in spending for seniors. So on net, there's going to be a lot less spending on senior citizens. And yet that ad made it sound like, boy, once seniors find out how this works, they're really going to like it.
Well, I thank you for that response, and I wasn't going to use the word fraud, but I guess bordering on fraud is acceptable language in your testimony, and I tend to agree with you on that. Dr. Goodman, how much authority does Secretary Sebelius have over Obamacare now that it is being implemented by regulation?
I don't know, but every time I learn about some new exercise of authority, I'm shocked. I've never seen so much authority that has been given to a secretary, nothing even close to it. And it bothers me because, there are elections, presidents come and go, secretaries come and go, and if a secretary has that much power, how do we know what's going to happen 8 years from now, 12 years from now? We're no longer a government of laws. We're a government of people and discretion and whims.
Mr. Goodman, thank you. Let me, in the few seconds I've got left, let me shift to Senator Vitale. Senator, you in your written testimony and what you said to us here today, you kind of touted what New Jersey has done in regard to the CHIP program and the fact that you cover childless adults. And I realize this goes back to Governor Whitman, but you talk about the fact that charity care went way down because you expanded this coverage of the CHIP program. I think it was something like 400% of the federal poverty level in New Jersey. Are you aware of the fact that most of these hospitals that provide charity care are not-for-profit? And in that status as not-for-profit, they get tremendous tax breaks, and it is their obligation to be designated as not-for-profit to provide this charity care.
May I respond, Chairman? Thank you. Well, you're right, but the fact of the matter is that the overwhelming amount of charity care has just really been debilitating for our state's hospitals. It is so overwhelming that they do meet their charitable obligation as not-for-profits. But to the extent now that there are so many uninsured accessing health care in the worst and most expensive manner in the emergency departments has pushed a number of hospitals into bankruptcy, into closure in our state, and those who are surviving are under increasing pressure from those who are uninsured.
Mr. Chairman, I realize my time is over, and I appreciate your indulgence. If you could just let me make this one comment. I mean, the point I'm making is that these hospitals, they're designated not-for-profit, and it doesn't mean that these patients are going to the emergency room to get their care. Most of these hospitals have outpatient clinics and the ability to provide the same level of care that they would be getting if they were signed up for S-CHIP or in one of these exchanges that the good senator is referring to. And I'll yield back, and I thank you for your indulgence.
Thank you. The gentleman from New York is recognized for 5 minutes.
You're right. The problem is they're not paid for. Ultimately, they have to pay for the bill fare. He doesn't come in and say to any kind of hospital, we're going to go pay your bills. By the way, Dr. Goodman, calling Andy Griffith a fraud is outrageous. He's one of the most beloved Americans. Oh, I'm just kidding. Let me just, Senator Vitale, let me ask you a couple of questions. There's been a lot of discussion by the two gentlemen to your right about the inflexibility and the federal government control that is being taken by this bill. Let me just ask you a couple of questions. State insurance commissioners were still kept in charge of state insurance policies in the 50 states. Is that correct?
Yes.
And didn't the Affordable Care Act not only do that, but empower them with additional tools they didn't have before on behalf of the residents of the state? Is that correct?
That's correct, yes.
Isn't it also correct that under the Federal Affordable Care Act, the exchanges, if the states so choose, are going to be set up as state-run, state-governed exchanges. Is that correct?
That's correct.
Isn't it also true that despite the efforts of many of my Republican friends, and perhaps the gentleman to your right, efforts to nationalize tort reform were resisted? Isn't tort reform still the purview of the states under this law?
It is, and always has been.
Isn't it also true that the expansion of Medicaid between now and 2017 is entirely picked up by the federal government? Is that
Yes.
true? Isn't it also true that in 2018, 19, 20, and 21, if there are fewer poor people bankrupted by health care costs, for example, more people working, more people employed, the number of Medicare beneficiaries, if your state is successful, will go down, will it not?
Yes, it will.
And with it will be Medicaid expenses, will it not?
Yes.
So, in fact, if you're a well-governed state and the economy does better, meaning less, God willing, 20% of the economy is health care, and people are employed more like they have been increasingly, more private sector jobs have been created under President Obama than under 8 years of President Bush. If it continues that way, Medicaid expenses could go down. Is that correct?
That's correct.
Now, if I can talk to you a little bit about some of the things that are required in here and just get your feedback on them. One is this notion of standards. The gentlewoman from Tennessee says, oh, one size fits all. But let's assume for a moment the citizens of New Jersey, through their state rights, say that we are going to have certain health care standards that are robust. We want to make sure that insurance actually covers people. And the state of Tennessee says, no, we're going to have a scaled-down program that has virtually no benefits but lower cost. Isn't it very likely that citizens of New Jersey, if they can go to that lower standard, the healthy ones will say, wait a minute, I don't need a lot of insurance. I'm going to go to the lower standards. Won't there be a race to the bottom, less insurance, and ultimately the same thing we have now, which is people who are underinsured? Wouldn't that be the effect?
That will be the effect, yes.
So the effect of having standards across state lines is to make sure there's fair competition between states. Next is this notion of mandatory coverage that is enshrined in Romney Care. Are you aware that under the mandatory policies of Romney Care, that with the subsidy, a very similar model that we set up, under Romney Care, a grand total of 0.67% chose not to take the subsidy and buy insurance. Are you aware of that?
Yes.
It's a very tiny number because actually, this is going to come as a surprise. The American people, when given a subsidy, they want the insurance. Now I'd like to talk a little about Dr. Goodman and Congressman Istook's solutions. They say, why don't we look at what Walmart does? And they're able to lower costs. If we just give people money, they'll go and buy insurance. Well, if you don't believe in the laws of big markets, and you don't believe in the laws of the economy, that more people joining together can negotiate for lower prices, you can do something. Maybe my father, when he retired at 61 with an instance of prostate cancer, was not yet eligible for Medicare. He went out as an individual and said, I'm going to try to buy insurance. So the insurance company said one of two things. One, we don't want you. You're going to get sick. Our business model is paying out as little as possible. Or two, they said $17,000 to $20,000 a year for my retired father. And the reason is very simple. Under Dr. Goodman's model, we can all be given money to go out and spend, and people like me and Congressman Istook, who's healthy as an ox, he'll be able to get insurance. But what do you do with the people who don't, who the insurance company says, I don't want it? Under Dr. Goodman's model, there are no standards, so you can't enforce standards. Everyone just gets a check. What you're doing is deconstructing one of the most powerful models that Walmart uses, which is when you get large pools of people, you're able to hold costs down. If you don't believe me, look at how auto insurance works. It aggregates risk over the whole pool. You say to each and every one of each and every citizen, go out and buy for yourself. You're resisting the ideas of a free marketplace and how it works and works best. And I got news for you, Dr. Goodman. You know who's going to love your idea? Insurance companies. They love the idea. Just give them money. We'll get some people come in with the money, but we'll get to decide who we want and who we won't. And you ignore the idea that sometimes what you've got to say is, you know what? Let's pool people together. And for those of you who are wondering, the idea of expanding Medicare, the boogeyman of the single-payer system, is they base it on that model. Because we have all these citizens, we hold down costs, and we aggregate everyone together. That's the way the system works correctly. I thank you.
The gentleman's time has expired. The chair recognizes the ranking member for unanimous consent request.
Mr. Chairman, I would ask unanimous consent to include the testimony of Jeff Levy of the Trust for America's Health and from Alan Wheel of the National Academy for State Health Policy. And I'd also like to add a fact sheet on your proposal, that's the chairman's proposal, to block mandatory funding in the Affordable Care Act. This was prepared by Mr. Waxman, our ranking member. I believe you have all of these.
Okay, without objection, so ordered. In conclusion, I would like to thank our witnesses, former Congressman Istuk, Dr. Goodman, Senator Vitale, for their testimony. I'd like to thank them and the members for participating in today's hearing. I remind the members that they have 10 business days to submit questions for the record, and I ask the witnesses to please respond promptly to the questions. Members should submit their questions by the close of business on March 23rd. With that, this subcommittee hearing is adjourned.